Well, thank you very much for asking me to talk on this topic of the future of experimental therapeutics and its application to patients with Parkinson's disease. What I want to do in this talk is take you a little bit through how we now think about Parkinson's disease in terms of subtypes and what might underlie that, and how we can then use that to inform us about using new therapies, mainly around cell and gene-based therapies, as well as strategies actually designed to get into the disease pathology itself. So Parkinson's disease, as many people will know, is classically defined by a pathology which targets the dopaminergic cells in the nigra. These cells acquire alpha-synuclein Lewy body pathology, which you can see in this figure, and that classically gives you the triad of disorders of movement, including a resting pill rolling tremor, slowness of movement, and rigidity. And whilst that's a very useful approximation of Parkinson's disease, and we know if we give dopamine drugs which target that network that's lost, patients do extremely well, it's not the whole story. So it's clearly much more than this. And one way in which we've tried to address this issue of looking at the different aspects of Parkinson's disease and how we can then categorise the patients into different subtypes is to take an approach where you collect everybody within a given community over a period of time, with the hope you can stratify in a non-biased way using this approach. So at the beginning of the century, we took this strategy and applied it to patients presenting with Parkinsonism in the county of Cambridgeshire in the east of England over a 2-year period. And during that period of time, we collected about 160 cases, which we have followed systematically since then. And we've also collected a number of other patients who at the time didn't have classical Parkinson's disease, but we didn't want to exclude them in case they had some form of FRUST or a precursor of Parkinson's disease itself. So we collected all these cases in a given geographical area over a given time, and we followed them up and continue to follow them up to this day. So at the time, this was the only population-based studies that had been done in this way for Parkinson's disease. So this gets around the bias that you have in only looking at patients who come to your clinic or you collect through some other route. So this is as it is in the real world. They're incident, so they were newly diagnosed cases, so they weren't people who'd had disease of variable length. And we've prospectively assessed and collected them, i.e. we have followed these people over time on the assumption that the natural history of this disease will vary between individuals and different subtypes of disease will emerge over time. So having collected all of these cases over a given area, or a given period of time, the next critical question in studies of this nature is, what do we mean by idiopathic Parkinson's disease? Because obviously the patients are referred to us by their family doctor with a diagnosis of possible Parkinson's disease or Parkinsonism. So we excluded all cases that had known Mendelian forms of Parkinsonism as existed at that time. And I can tell you that was no cases, because we had no LRRK2, we had none of the other genetic mutations associated with Parkinson's disease. We excluded people who fulfilled diagnostic criteria for Parkinsonian plus syndrome, such as PSP or MSA, and we excluded those from subsequent follow-up and analysis. We also excluded, at least at the beginning, those cases of secondary Parkinsonism, on which the most common was those induced by drugs such as antiemetics and such like. But we did watch and follow these patients because it may be that the drug simply brought out incipient Parkinson's disease. And then we also had to exclude people who didn't fulfill the criteria by which we were diagnosing patients, which was the UK PDS Brain Bank criteria. So using those criteria, we then defined idiopathic Parkinson's disease within this given area over this given time as having Parkinson's disease using this particular approach. And we know from other studies, particularly those by Andrew Lees done down in London, that if you apply these criteria in people who are used to seeing people with Parkinson's disease, you're right in over 95% of cases. So we collected all cases of Parkinsonism, we defined what we meant by Parkinson's disease, we did it in a strict area over a strict period of time, and then we were comprehensive in the data that we collected at the time, not because we thought that there were particular patterns that were emerged, but we thought that if we collected substantial amounts of data, it would be much more helpful in defining the different types of disease over time and how one set of symptoms correlated with others. So we obviously took basic information about history and demographics. We took a series of motor assessments, cognitive, of which we did a lot because we were particularly interested in the cognitive deficits of Parkinson's disease and particularly the dementia, neuropsychiatric features, some assessment of sleep, functional, And we also took DNA, which at the time we weren't entirely sure why we were doing it, because there weren't really many genes known for Parkinson's disease, and it wasn't clear how that would inform us, but subsequently turned out to be an extremely valuable part of the study. So this is how we've collected patients over time. So as I said, in the baseline over the 2-year period, we collected 239 people who had Parkinsonism, of which at baseline, i.e. in 2000-2001, 159 fulfilled the UK-PD brain bank criteria for Parkinson's. Those 159 were then followed up along with the other 80 patients who actually had Parkinsonism, and at 3 to 4 years we diagnostically reappraised the patients, and therefore we had 121 who now fulfilled the UK PD brain bank criteria for Parkinson's, and we've subsequently followed them up, and we're about to follow them up again. So as you can see from this figure, there are a number of issues that emerge with studies of this nature. First of all, the number of patients diminish quite quickly. And the reason for that is that the average age of Parkinson's disease in this study and in other similar based studies is 70. So 10 years into the study, the average age is 80. So it's not surprising that 63 of the 159 patients have actually died. And indeed, if you actually look at the mortality rate of patients with Parkinson's disease and compare it to a similar age and sex max group, at least in the United Kingdom, there is no increased rate of mortality associated with Parkinson's disease. The death rate in patients who have Parkinson's disease is exactly the same as a similar population of that age without it. You can also see that 30 of the patients withdrew from the study, which again is not surprising. As people are approaching 80, they don't necessarily want to be followed up and assessed in the intensive way in which we've done it. So that of course creates a problem, because now you're losing a substantial amount of power because you're losing your patients. But the power and the strength of these studies is that you're following people who are newly diagnosed over time. And so that gets around many of the problems of selection bias and looking at prevalent cohorts of different disease duration. So we followed these patients up over time. So just to recap, we've collected a group of people with Parkinsonism in a given area over a given period of time. We've said very specifically what we mean by Parkinson's using standard criteria, and we've done a number of detailed assessments of them, and we've tried as hard as possible to follow them over time. The next thing you do in studies of this nature is you then say, well, what does that look like? What is it actually that we've found? And amazingly, this was the first study really to report on the natural history of incident Parkinson's disease in the post-levodopa period. And so what we found is we found a number of interesting findings. The first was, if you look at this particular figure here, the time it takes to develop critical landmarks or milestones in the history of Parkinson's disease. So in figure A, we can see the number of people without postural instability, which corresponds to the Hernan-Yahr stage 3. And by 10 years into the illness, 2/3 of the patients have developed that particular problem. If we look at dementia in figure B, we can see that by 10 years, 40% of the patients have demented. If we look at those who've survived, I've already talked about that. But interestingly, in figure D, we looked at a group of patients who are still alive at 10 years, did not have any major cognitive problems, did not have problems with gait or postural instability. And these we described as having a good outcome. And I think this is an interesting area for the future, is why is it there's a group of patients who 10 years into their illness have done so well. So here we are, 10 years into the condition, and about a fifth of patients are doing extremely well. They tend to be younger patients, they tend to have more tremor-dominant disease. But it is an interesting observation that there are clearly some people with Parkinson's disease who do extremely well. So not only can you describe what's happening in Parkinson's disease, and therefore you can start to see, well, why is it that some people develop major postural instability problems? Why is it some people develop dementia? Why do some people do well? You can also start to assess the natural history of aspects of the disease, which will inform you about doing disease-modifying trials. So here we have a graph showing you the mean gradient change in aspects of the Unified Parkinson's Disease Rating Scale, different parts of it. So the motor scale, which of course is the most commonly used, shows a 2.1% worsening per year in a group of treated patients in this incident cohort. You can look at activities of daily living, the part 2, and you see 3.3%. But what we were particularly interested in was trying to get some marker which might correspond to disease pathology, which isn't as sensitive as other aspects of the UPDRS to symptomatic therapies. And these are these DOPA-resistant aspects of the UPDRS score, things such as gait, things such as speech, which don't respond as well to dopamine therapy. And here you can see that there's a very distinct decrease, which is quite large, 4.6% per year. And that could be used as a measure by which to look at a disease-modifying therapy. So in other words, if I took 100 patients newly diagnosed from the community, I treated them with a disease-modifying therapy or a putative disease-modifying therapy versus placebo, you could see that over the course of 5 or 10 years, you would expect the patients to have got worse on these aspects of the UPDRS between 23 and 46% worse on those scores, which is a large measure, and therefore one should have greater confidence in knowing whether one's got a disease-modifying therapy using measures such as that. Obviously, having described it, whilst that's interesting, what would be quite nice is then to try and stratify your patients into subtypes and then try and understand why it is that they behave in this different way. So as I've said, using this approach, we can say that there are essentially two major types of Parkinson's disease. There are those who seem to do very well, which tend to be the younger patients. They may have some subtle cognitive deficits, but essentially don't have any major problems. And then there are these older patients who have deficits which are predictive of a dementia. So if you're not very good at producing lists of animals or drawing interlocking pentagons, then you have a greatly increased risk of developing an early dementia. It's also linked to some extent to poor gait, postural instability, and gait disorder, which is the Hernian stage 3, if you like. So there's clearly a group of people who do badly, who tend to be older patients with these cognitive deficits, who dement early with postural problems. And there are those patients who are younger, who have tremor-dominant disease, who may have some subtle cognitive deficits, but generally speaking do very well. And we would postulate, although we have no data for this, that they have a different pathological basis. We would say that the younger patients have a much more focal disease, or at least a disease which doesn't advance very quickly and tends to mainly localise around the nigrostriatal dopaminergic system. Whereas the other patients, the patients who do badly, the more elderly patients, have a disease which is a more malignant disease process and spreads out very quickly from the basal ganglia and the nigral system into the cortex, causing these more global problems, as well as pathology throughout the brainstem. So we've sort of described what we found. We postulate that there are these two main types of Parkinson's disease. Then the question is, how do we explain it? What is it that's different about these patients other than age? And one of the interesting areas which we chose to explore was around the genetics. Now, it's known that there are a number of genes associated with getting Parkinson's disease or increasing your risk, of which the two commonest are alpha-synuclein and the tau haplotype. And what we found looking at this cohort is if you follow patients over time, as we have done, a particular type of tau haplotype predicts a worsening cognitive performance. So if you are H1 tau haplotype, your chances of dementing is greatly increased over those who are H2 carriers. So not only does the tau haplotype increase your risk of getting Parkinson's disease, but it actually also seems to have some role in accelerating the disease process and pushing you towards a dementia. So clearly tau is involved in the disease process and driving the disease process in these different types of Parkinson's disease patients. The other gene which we became interested in more recently is the gene associated with Gaucher's disease. So I'm sure, as many of you know, Gaucher's disease is an autosomal recessive disorder where you a lysosomal storage disorder. There are different types of it, and it's due to normally compound heterozygote mutations in the GBA gene. It was noticed a number of years ago that families with Gaucher's disease had a higher incidence of Parkinsonism within it, and then it became clear that the GBA gene in some way was associated with getting Parkinson's disease. And if you look at the major studies now, somewhere between 5 and 10% of patients with so-called sporadic Parkinson's disease carry a single heterozygote mutation for the GBA gene. What we found was something very similar. We found in our incident cohort that was the number that we found. 10% of our patients had a GBA mutation. But not only has this GBA mutation been associated with Parkinson's disease, but in our study what we found was that the known GBA mutations versus the questionable polymorphisms had a profound effect on the disease course. Namely, if you carried one of the known mutations, all of the patients had demented within 8 years, whereas one of these functional polymorphisms had an intermediate effect over those who carried no such mutation. In other words, the tau haplotype and the presence of a GBA mutation not only increase your risk of getting Parkinson's disease, but they have a dramatic effect on the disease course. Namely, they drive the disease in a much more malignant, aggressive fashion, and that's why some patients do worse, and presumably those who do well do not have this genetic predisposition. Now, of course, having defined what the genetic risk factors are for driving the disease course, the question is, well, how? How is it that a GBA heterozygate mutation drives Parkinson's disease pathology in a more aggressive way? How does the tau haplotype impact on that? And I don't have an answer to that, but one of the strategies that we've taken is to try and model it in the lab. So what we do is we take patients with different genetic backgrounds, different tau haplotypes, different GBA mutations or non-mutations, and we've tried to model it using cells that have been grown from them in terms of various different inducible transdifferentiated cells. We know already, if we look in the brains of people who've died with Parkinson's disease, that this change in tau haplotype, or your tau haplotype, does change the ratio of 4:3 repeat tau, which is thought to be critical in disease expression. Exactly how is unclear. So we know that there are some subtleties just looking at post-mortem tissue. As I say, we haven't looked at post-mortem tissue in great detail in our cohort to date. But the plan is actually to take cells from these patients, transdifferentiate them either directly into neurons or into inducible pluripotent stem cells, drive them into neurons, and then start to try and understand the pathology in the patients that we followed over time in the lab. So to sort of summarise this part of the talk, what we've managed to describe over the last 15 years is that there seem to be two types of Parkinson's disease from disease onset. One is a younger group of patients who tend to have tremor-dominant disease, subtle cognitive deficits, who 10 years down the line are doing very well. We have an older group of patients who have subtle cognitive deficits at presentation, which are quantifiable in terms of poor semantic fluency and visuospatial function, who have specific genetic variability or variations around these tau haplotype GBA mutations. And these patients do badly. They develop an early dementia, they develop an early gait disorder, and they have a much more malignant disease process. So having defined these two types of Parkinson's disease, what does that mean therapeutically? Does it have any implications? Well, in some ways you could say it has implications today, because the patients who are going to do badly probably need aggressive treatment with symptomatic drugs now. We need to look out for the problems and we can warn them that they've got a poor prognosis. Conversely, the younger patients we can say are unlikely to run into problems for at least 10 or 20 years, and we can probably control them much better with relatively less aggressive disease drug therapies. However, in the world of experimental therapeutics, it also has major implications. So in those patients who are the younger patients with a much more dopamine-centric disorder, they are clearly the patients who are going to do well with drugs or therapies designed to restore the dopaminergic network, whether they be new dopamine drugs, whether they're cell therapies designed to replace the dopamine cells, or gene therapy designed to either rescue dopamine cells or to actually produce dopamine. Those who are going to do badly, so those on the other side of the curve, if you like, they are the very patients who will do extremely well with disease-modifying therapies around particular drugs which get into the pathology, because clearly they've got a bad prognosis, they're going to do badly, they have a very clear endpoint that they'll dement within 5 years, and it's actually that group that should be targeted much more for disease-modifying therapies. So I'm now going to talk a little bit about these dopaminergic therapies and how we can best apply them to Parkinson's disease, and how this new information informs us about some of the problems that have happened in the past. So one of the important things when you come to think about cell-based therapies for Parkinson's disease is that all cell-based therapies to Parkinson's disease to date have worked around replacing or restoring the lost nigral dopaminergic input to the striatum. These therapies will therefore only be as good as the dopaminergic therapies that are out there now. So this is not a cure. You're not curing Parkinson's disease with this. All you're doing is putting back the dopamine tone, which is lost as a result of the disease process. Now we know in early stage patients, if you give them dopamine drugs, they do extremely well. So there's every expectation that this therapy will do very well, but it's important to understand this is not a cure. You are simply targeting one aspect of a much more diffuse pathology and symptomatology. Now, in the world of cell-based therapies for Parkinson's disease, probably the best used and best studied tissue with the most consistent results are those which involve transplanting in the fetal dopamine cells which develop in the midbrain. So in the late 1970s and early 1980s, in pioneering work done by Anders Björklund in Sweden, they demonstrated in rat models of Parkinson's disease that if you dissected out and prepared the developing dopamine cells from the ventral midbrain of embryos, put them into the brain, adult brain of animals that had had dopamine lesions, you could restore behaviour back to normal. The transplant survived. Dopamine cells differentiated out of the ventral mesencephalic transplant. They made processes which innervated the brain. They received connections from the brain, and they released dopamine. So during the 1980s, it was clearly demonstrated that this approach, using fetal dopamine cells derived from particular ages of fetus, could restore dopamine function in these animal models. And this led in the late 1980s to the first studies being done in patients, and continued during the 1990s, largely in Europe through open label studies. Open label studies are essentially studies where the patient knows they're getting the therapy, the physician knows they're getting the therapy, everyone knows they're getting the therapy. So it obviously runs the problem of a bias. Everybody knows they're getting it, so it could have a major placebo effect. But in one of these early patients, so if we look at the graph at the top, in patient number 4, who was a patient transplanted in Lund in Sweden in the late 1980s, they had a transplant of, I think, in the region of 4 VMs from human aborted fetuses. So essentially you collect a number of aborted fetuses, you recognise and dissect out the developing ventral midbrain, you turn it into a cell suspension, and you injected it into the brain of one patient with Parkinson's, into the area where dopamine normally works, namely the striatum. And in this particular patient, what we found was that prior to the operation, they spent 2/3 of the day off. So despite having optimal drug therapy as existed in the late 1980s, the drugs didn't work for 2/3 of the day. Over a 3-year period, having had a transplant on one side of the brain, the patient improved to the point that 3 years after the transplant, they were now on all day, i.e. they were off for none of the day. And that improvement took place whilst having all of their dopamine therapy stopped. So 3 years after a unilateral transplant of fetal dopamine cells from aborted human fetuses, the transplant had taken the patient from being off for 2/3 of the day to on all day in the absence of any drug therapy. And on their PET scan, which you can see below, which was done at the Hammersmith Hospital in London, using fluorodopa, which picks up presynaptic dopamine terminals, you can see at the site of implantation, there's a slow increase in signal, which parallels that of their clinical improvement. You can also see that on the non-grafted side, i.e. the side which was left to the disease process, that the dopamine cells have actually continued to die on that side. So these early open label studies showed a proof of concept. They showed that if you transplanted patients using the same approach as you'd used in the lab, it would produce a significant clinical improvement out of keeping with anything you would see normally. And that clinical improvement married to a change in fluorodopa PET scan in keeping with graft survival and fibre outgrowth, just as one had seen in the experimental animal models. So this was very encouraging, but you can also see on this figure that patient number 3, who I've skipped over, didn't improve so much, their PET scan didn't improve so much. So there's clearly inconsistency in this approach, but nevertheless, as a proof of concept, it was proven. As a result of these open label studies in the early 1990s, it was decided in America that this now needed to be the subject of a more rigorous trial in which patients were recruited to either have sham surgery or imitation surgery or real surgery to get around this issue of whether there was a placebo effect. So NIH funded 2 studies where patients received either imitation surgery or implants of fetal tissue. And the first of these published in 2001 in the New England Journal of Medicine and led to headlines such as this, which is in a paper in the United Kingdom, The Guardian, but was seen in other papers around the globe, which again emphasises the problem with this field is that these type of therapies tend to attract headlines which have a degree of hyperbole. Miraculous cure turned into a catastrophe. So what was this miraculous cure that turned into a catastrophe? Well, it was the first of these studies, which, as I said, was published in the New England Journal of Medicine in 2001, and the second NIH study published in the Annals of Neurology in 2003. In this New England Journal of Medicine paper, the essential study was you took 40 patients with Parkinson's. Everyone went to theatre, 20 of them had a transplant, 20 did not. The transplant was prepared in a very different way to how the European studies had been done. The end point was at 1 year, the patient was phoned up and asked whether they felt better for the transplant. The conclusion was that they did not feel better for the transplant, so the primary endpoint had been failed. As part of the study, those patients who were randomised to have imitation surgery were offered the transplant, so 20 of the placebo-treated arm, if you like, were taken forward, of which 13 had a transplant. Slightly worrying was that 5 of the 33 patients who were grafted developed these so-called graft-induced dyskinesias, so these involuntary movements, which you see in anyone who takes L-DOPA with L-DOPA, which can obviously be stopped because you can stop the L-DOPA, but now they were seeing these dyskinesias which were occurring in the absence of L-DOPA but the presence of a transplant. And these were clearly a problem because I can't get the transplant back. They were so severe in a couple of cases that the patients had to go on to have deep brain stimulation, but thankfully deep brain stimulation seems to work as well in these patients as it does for the L-DOPA-induced dyskinesias. However, this was a significant setback for the field because it was now saying that in a more rigorous trial, as it was seen by many people, it didn't work and it produced side effects. And that was reinforced by the second study, which, as I say, published in the Annals of Neurology in 2003, that showed that using a similar approach, here they now had 34 patients, 11 had a transplant with a small amount of tissue, 12 with a bigger amount of tissue, and 11 with no tissue at all. This now used a different endpoint. At 2 years, they used the Unified Parkinson's Rating Scale in the defined off. And what they found was, although there was a trend for improvement in the patients who had the transplants, especially with the greater amount of tissue, this did not reach statistical significance. And now they saw these graft-induced dyskinesias in 54% of patients. So this led many to conclude that this whole approach, whilst being of interest, clearly didn't have any mileage. It came out in the context also of deep brain stimulation becoming a well-established therapy. So most people said, why bother with this when deep brain stimulation is clearly the best way to treat people with advancing Parkinson's disease? And whilst that's an interesting perspective to take, one has to also look back and say, well, why is it we still have patients who've done extremely well? So here are 2 patients from London who were transplanted in Lund. These patients have now had Parkinson's disease for approximately 30 years. They've had transplants for anywhere in the region of 10 to 15 years. And what you can see on this is that not only has their F-DOPA scan gone back to normal, i.e. they've got normal dopamine levels in the striatum, clinically these patients using the Unified Parkinson's Rating Scale have gone back to a level of disability which is less than that which is what they had when they presented with their Parkinson's in the first place. And in both of these cases, the patients are on no dopamine medication. So 30 years into the illness, 15 years after a transplant, you have some patients who are on no treatment who look almost normal with respect to their movement disorder, i.e. they don't look as though they've got Parkinson's disease. So it's very hard to say that this therapy doesn't work. What one can say is it doesn't work consistently. So as a result of this great tension between the interpretation of the double-blind placebo-controlled trials in the States and the open-label studies in Europe, we set up a working group to re-evaluate where we'd gone with transplants and to try and move the field forward with the hope that that will lead to new trials with stem cell-based therapies. And so in a recent review, we sort of summarised what you can say about the use of VM transplantation in Parkinson's disease. What you can say is that it's pretty safe. So if it's done in centres that know what they're doing and have a history of working with fetal tissue, there are no neurosurgical concerns. There are no major hemorrhages. There are no tumours. You can also see that some patients do extremely well with this therapy, as I've already intimated. So there is a significant proportion of patients who have a major improvement in their clinical condition, which is present and lasts for years after they've had their graft, to the extent that some of them can even stop their medication. You can also say, as you can see in this scatter plot, that it doesn't work for everybody. So this is clearly not a therapy that we've optimised or is suitable for all patients with Parkinson's disease. There are clearly problems with it. You can get bad graft-induced dyskinesias, you can treat them, but nevertheless that is a concern. Why do they develop and how do they develop, and can we avoid them if we're ever to take this therapy forward? And finally, something I haven't really mentioned but has been very topical, is that some of these patients have subsequently died, and it's been shown that in their transplants they have some Lewy body pathology in the grafted cells. This has raised many interesting questions about what goes wrong in Parkinson's disease in terms of pathogenesis. Some people would say it means that your transplant can't survive because it will develop the pathology you're trying to treat in the first place. My own view on this is that the number of cells affected is relatively small, and we know that these transplants can work at least for 15 years in some people. So whilst it's of interest, I don't think that's a reason to not do it. So as a result of this, we were fortunate enough to be funded through the European Union to set up a new trial which tries to address some of these issues so we can get a more consistent and robust response. And this is the Trans-Euro trial, which has been running for a number of years. So in this rather complicated slide, it's really designed just to illustrate how the trial has been configured. By looking at the data, it appears those patients who do best with transplants are the younger patients with less advanced disease and without significant levodopa-induced dyskinesias. So we've collected a group of patients who have those characteristics. We've tried to optimize how to prepare and implant the tissue which gets around some of the problems associated with graft-induced dyskinesias, namely the presence of 5-HT neurons at a greater level than dopamine cells and inconsistent and inhomogeneous delivery of the cells to the striatum. So by dealing with how better to prepare the tissue, how better to deliver it, and how better to select the patients, we now feel we're in a better position to get more consistent and robust results using a longer endpoint, because we want to see that we get a significant effect that gets past those immediate placebo effects that many people worry about with this type of therapy, because we're not doing sham surgery in our particular trial. What we're doing is we're grafting patients who are selected out of a bigger cohort of historically matched patients with the hope we can compare the two. So this will enable us, we hope, to get more robust and consistent results, but this will never be a mainline therapy for Parkinson's, not only for the ethical problems associated with using fetal ventral mesencephalic tissue, but practical problems in that every patient requires anywhere in the region of 4 to 12 fetuses to graft both sides. So we see this as a stepping stone for future stem cell transplants. That, of course, raises the question as to what stem cell are we thinking of might be useful for patients in the future. Now, as you know, there are many types of stem cell, from those in the adult which reside in the bone marrow, the hemopoietic stem cells, even stem cells in the adult brain, to those which are derived from the developing embryo or fetus. Now, each has their own merits and disadvantages, and I don't have time to talk about that today, but there seem to be two major front runners of stem cells likely to come to clinic with Parkinson's disease. One comes from the spare embryos from IVF programs, so the ES cells, the embryonic stem cells, and the other relates to this new technology of reprogramming adult somatic cells back to a pluripotent stem cell state and then driving them to dopamine cells, or direct transdifferentiation of fibroblasts or adult somatic cells to neurons. Now, why do I say that those two are the front runners? Well, the reason why I think embryonic stem cells are the front runner is in a very important paper by Lawrence Studer published in Nature in 2011, and also by another approach by Marlin Palmer's group in Lund. They have taken a developmental approach to take the human embryonic stem cells, push them into dopamine cells using normal developmental signals. And by taking this approach, they've demonstrated that you can get authentic nigral dopamine cells, which are the dopamine cells you need to work in Parkinson's, not just any dopamine cell, but an authentic nigral dopamine cell. And they've demonstrated that these cells are safe, they don't form tumours, they turn, as I say, into bona fide nigral dopamine cells, they make dopamine, they make synapses, they make processes, they release dopamine, and they work in a variety of animal models. So the challenge now is whether we can improve on some aspects of those cells, such as their maturity, their fibre outgrowth, and whether we can do it using reagents which are of an appropriate grade to be used in the clinic. But I think the prospect of taking human embryonic stem cells and turning them into dopamine cells for grafting in patients is a realistic possibility. And I think that is the most likely cell source to go to the clinic. The other, as I say, is the ability to take the patient's own cells and reprogram them. That surrounds a lot of the ethical problems associated with embryonic stem cells. So here the strategy is that you take some cells from the patient, for example, such as a skin biopsy, grow up the fibroblasts, reprogram them, turn them into dopamine cells, and use that as your source for grafting. And that has been shown to work in animal models. So you can take the skin from mice, turn them into iPS cells, turn them into dopamine cells, graft them, and they have functional benefit. And more recently has been this new technology where you directly transdifferentiate cells from a fibroblast into a neuron, so-called inducible neurons. This has been shown in animal models. The question is, of course, if you use this as a strategy in patients, so you take the patient, you take their skin cells, you reprogram them in the lab and then transplant them back in, would you ultimately want to use those cells? Because whatever the risk is for the patient of developing the Parkinson's disease in the first place, they will still presumably reside in the neurons that you've now derived. So they might not be the optimal cell to put back into patients. Another approach around trying to replace dopamine is to use gene therapies, and there are a number of gene therapies that have been tried. Some of the gene therapies have been used to actually promote the growth of dopamine cells, such as nurturing, direct growth factors such as GDNF. But one therapy that we've been involved with rather indirectly, but nevertheless we've had a few patients, is around a gene therapy called prosavin, where essentially the idea has been that you produce a viral vector in which you put all the synthetic enzymes for dopamine, and then you can inject it into the patient's striatum with the hope that it will make dopamine within that structure. So this has been done now in Paris in collaboration with a company called Oxford Biomedica, and we've been involved with the latter stages of it. So just to recap, the idea here is you take patients, you inject into their striatum, the area where dopamine's lost, a gene therapy. The gene contains the synthetic enzyme for dopamine. So you're not repairing the network, you're simply producing more dopamine. And so what they did was that they found this was very effective in the non-human primate models. The dose which was effective in non-human primates, they then applied to patients. That was safe. They got some signal of efficacy, not a great signal. So then they doubled the dose because, of course, the non-human primate brain, especially the one they were using, is 5 times less, is a 5 times smaller volume than the human brain. So clearly it was always going to be a suboptimal dose. So they doubled the dose to check it was safe. They then worked on a better way to deliver it across the greater structure of the striatum and did 3 patients using a new delivery system. And then ultimately they increased, so they were 5 times the original dose, did 3 patients in France, 3 patients in Cambridge. And the upshot of this is that these patients actually seem to be doing extremely well with this therapy. It seems to be safe, there seem to be no major serious adverse events, and there doesn't seem to be any major antibody response to the gene therapy that's been given. So this is a different strategy. So to sort of summarise, whilst I've only picked on 2 examples here, namely a fetal cell-based therapy and a stem cell-based therapy and a gene therapy, any approach which is designed to work around the dopamine cell system may best be targeted at that particular group. As I said at the beginning, those elderly patients who tend to do less well may be the ones for disease-modifying therapies. And I obviously don't have time to go through all of those therapies. But one interesting area, which I just thought I'd flag up towards the end of my talk, is the idea that there are drugs out there already which could be rebadged for use in Parkinson's disease. So there are a whole series of drugs which are used for various different medical conditions which have experimentally been shown to have effects on animal models of Parkinson's disease or cell models of Parkinson's disease. So here, for example, are a whole series of drugs which were recently discussed at a conference organised by the Cure Parkinson's Trust in the UK. So some of these you will recognise as standard drugs such as metformin, commonly used in diabetes. This is a drug which has been shown to have some efficacy in animal models of Parkinson's disease. So, of course, one of the arguments is that you take drugs which are already out there and you rebadge them and you do trials in patients with Parkinson's doing this. The advantage is you don't have to worry about safety because there's a large volume of data on how safe they are to use in humans. Of course, the big issue is whether the drug dose that you use for your primary indication, so metformin, say, for polycystic ovaries or for diabetes, is the same dose that you would need for using in Parkinson's disease. But as a proof of principle how this works, Tom Falsney, my colleague in London, recently published a paper in the Journal of Clinical Investigation where they took a drug, exenatide, which is used for diabetes, a GLP-1 agonist, and demonstrated in patients with Parkinson's disease that it could have some possible disease-modifying effect. The reason they chose this drug was this drug had a long experimental history of being useful in Parkinson's disease models, and so it was tried in patients with moderately advanced disease using a new sort of trial design and showed some signal of efficacy, which now opens up the potential to take this forward in a more rigorous, bigger study, which I'm pleased to say has been funded now and will take place. So to summarise, the most important thing I wanted to get across today was the idea that Parkinson's disease is not a single disorder, but that you can stratify it into different types of disease. Not only can you do that using strict epidemiological studies following patients over time, but we now, with modern genetics, can start to understand what might underlie that. Until such time as we fully understand the pathogenic pathways in Parkinson's disease, we have the potential to use experimental therapies by stratifying patients into those who seem to have a more benign dopaminergic-centric disorder, and they will do extremely well with drugs which look at that network, such as cell therapies, gene therapies. And there are clearly an older group of patients who do less well, who have more rapidly advancing disease, who may be the very best patients by which to look at disease-modifying therapies. And that's not just developing new therapies based on pathogenic pathways as we understand them in the clinic, as we understand them in the lab, but may involve a complete sea change in trying to rebadge old drugs which are already out there for early trials in Parkinson's disease. And with that, I would like to conclude and just thank all of the people who funded our work over the years, and all those who've actually done the work in my own lab, of which I've only mentioned a little bit, and all of those we collaborate with both within the UK and internationally. Thank you very much.